flexion. This takes practice as far as visualizing the landmark, okay? So we want you to expose the landmark by adjusting the clothing accordingly, drape if you need to. But I'm going to find that acromion, okay? And then I'm going to kind of visualize it. And remember, as the person comes into flexion, what's going to happen? My acromion is going to be kind of occluded. I'm not going to be able to actually see it. And if I want to try to come in and palpate it, it's going to be underneath the person. So I have to maintain a kind of a visual placement of that acromion as the patient moves. Okay, and my stationary arm will be aligned where? Yeah, midline of the thorax. And my moving arm is aligned with the midline of the humerus towards the which epicondyle? Lateral. This is important, right? So that one you should be able to see. And the cue, okay, again, is that I usually have the patient say, kind of with your thumb pointing upwards, drive your arm up overhead, keeping your arm close to your ear. Okay, I don't want you to bring your arm out to the side, and I don't want you to turn your thumb outward or inward as you come up. Your thumb's going to come straight up overhead, and I want you to go as far as you can. Okay? Sometimes people may try to move their head and ear, but mostly we just want them to try to avoid moving their arm out to the side. And then sometimes, because normal shoulder elevation is associated with a small amount of thoracic extension, you may see someone try to arch their back a little bit on the table. So, some of that is normal, but we really want to minimize any of that excessive arching off the table. Okay? So just be aware of that. We'll go over that a little bit more next week. Okay? And what is normal range of motion for shoulder flexion? So I should be able to start at 0, down by my body, and I should be able to bring it all the way up, okay, perpendicular to the floor. 170 to 180 is what most people agree on, but 180 for our purposes is pretty normal, okay? So, Anna, what I want you to do when I say go, with your thumb relatively pointing upwards, I want you to keep your elbow straight, and I want you to drive your thumb up overhead, trying to keep your arm kind of close to your ear as much as possible. Now, with this setup, what's going to happen if I want to assess her ability to go through normal range of motion, what's the problem with this setup?
The pillow's
Aha! The pillow may prevent her from going into a full 180. So, if you want to keep the pillow in place, you need to slide it over so that she has free range to go all the way down towards the table. Okay. Measurement. Acromion. Midline of the trunk. I'm going to raise you up as much as I can. Anna, when you're ready, you should bring your thumb up overhead as much as possible. Keep that arm close to your body. Lateral epicondyle. Eye level. Is that as far as you can go? Keep that elbow straight. Bring it down. And relax. She has about 167. A little tightness, but not terrible. Anything on that one?
Nothing. Just what happens when you need to do it passively?
Oh yeah, we're
they
going to talk
can't
about
do it
that.
actively themselves.
That's right. So, I don't know exactly what you're talking about, but basically hand placement and all that. So, what I'll often do is I'll often kind of hold just proximal to the elbow and then proximal to the wrist. And what I'll do, okay, I think it's kind of awkward for me to do this. You can do this, but I like to kind of switch it up. And I like to kind of help guide. Sometimes they need a little overpressure if they're tight. So I kind of switch over.
So how do you measure that with the goniometer?
Oh, that's what you
measure
want.
passive range of motion with a goniometer.
This is tricky. Okay, so this is tricky. Good.
I don't want anybody to get in the clinic next year and have an anxiety attack because they don't know how to do passive range of motion of the shoulder.
Okay, well, here's the reality, if I'm being honest, okay? So, ideally, the test is done with the arm completely straight. But the landmark is proximal to the elbow. So if you have to, you can make the lever arm a little shorter, and you can grasp the forearm and do it if you need to. That's an option, because that makes it easier for you to control the arm versus trying to keep the elbow straight and move the patient through passive range. So that's just a little tip. Sometimes I'll gently grasp the forearm, and I'll drive it overhead this way. Now, It's really important to have a goniometer that's not too loosey-goosey, because it'll be hard to maintain. So what I'll usually do is I'll bring them through, and I'll look at how far I think they can go relatively. Okay? Because I have to take the measurement fast using 2 arms and supporting someone's arm. And I'll say, alright, that looks like it's about 125. Then bring it back down. Okay, and I'm going to lift your arm up overhead. Okay? And usually I'll try to move them up as much as possible. And then what you can do is you can slide your thumb down to kind of hold the moving arm, if you can. Okay, relax your arm there, you're not relaxed. Okay? And you can maintain the goniometry placement. And I can use my, I don't know if you guys can see it, but I can actually use my, I have this reversed, but you can use your palm to try to block the goniometer and move as they move. So, I'm stabilizing the goniometer. I can manipulate here. This is a little harder for me. I'd rather stabilize the moving arm here, and then as they move, the goniometer moves with it. I'm maintaining the axis with my right hand, and I'm maintaining the stationary arm, and then the moving arm goes as we move through the range of motion. Now I'll recheck the landmarks, I'll take my measurement, and then I'll gently guide them back to the starting position. Is that what you're kind of looking for?
Yes, perfect. Yes, yes.
So, practice that, okay? Because it can be awkward. I would generally try to say, if you can try to maintain the goniometer with your palm and move as you move them, that's best. Some people use their thumb. Some people will try to do this. I'm not a big fan of that. It's harder to be accurate with this, especially if someone's arm is heavy and they're in pain. You don't want to be fumbling around. Set them up and move with them. Take your measurement and be done. Is my advice. Okay, now let me have you. Can you flip over onto your stomach over here? This way. We're going to do the same one. Okay, we're going to look at extension. Landmarks are relatively the same. And I believe it's just the opposite. So your thumb should be pointing downward, I believe. And then they lift up. Palm, is it palm facing up? I think that's the MMT.
MMT is palm up.
Huh? Yeah, palm facing trunk. So it's just the opposite. So the thumb was pointing upward, now the thumb is pointing downward. Landmarks are the same, still okay. Lateral epicondyle, midline of the trunk, and the, go ahead and lift real quick, and go ahead and relax. And I believe that for this test, the patient should be looking away from the testing arm for range of motion. Okay, so Anna, what I want you to do, when you have a chance, I want you to try to maintain your trunk, okay, down as you move. All I want you to do is lift your arm straight up towards the ceiling. Right. I want you to keep your elbow straight. And the tendency for patients is going to be to come out into some abduction. That's very common. Okay, and what's normal range of motion? Does anyone remember?
Is that 45?
I think
In the Moodle book, the orthopedic surgeons say 50 to 60.
Yeah,
That's way too much. That's a lot. That's a lot.
I mean, so if someone's unrestricted and their thorax isn't blocked, you know, you can probably get that much in a standing position. In a functional position, you probably can get that. In this position,
no cheating.
I would say, usually I'm happy with 30 to 40.
Yes,
but
exactly. 30, 45.
So just remember, if you do test it, if someone's unable to lie prone for some surgical precaution, they're elderly, they can't tolerate it, they don't want to do it, you may be able to get that 60 in a functional upright position. But so again, you're going to have the patient keep their thumb pointing down towards the table, elbow relatively straight, thorax in contact with the table, head turned away for the range of motion, and you're going to have them lift their arm straight up. Lift your pinky straight up towards the ceiling. Keep your arm close to your body. Just see how she's kind of doing a little A-B?
Yeah.
So I want you to stop right there, and that's where I would measure. Now come back down. Can I go ahead and lift one more time? Lift. Can I try to lift more like you really, really wanted to? Cheat. So she's lifting up a little here. Mm-hmm. You come back down. Good. Okay, now ready this time. I'm going to measure. You feeling okay still? Sorry for all that testing. Okay, go ahead and lift your arm up towards the ceiling. Lift that pinky straight up. And relax. So she got about 38. And I think that's pretty good. Is this your dominant arm?
Yeah.
Yeah, that's pretty good. So, again, watch for that abduction. Watch for, kind of lifting. Yeah, exactly. Kind of that rotation of the trunk. Watch for maybe some rotation through the shoulder. And make sure they keep their elbow relatively straight. Okay, relax now. And then I would say I don't do a lot of passive range of motion for this one especially, but same thing would apply, where you would hold, you kind of hold near the elbow, and as you lift them up, you're trying to maintain the goniometer as you move the extremities through the moving arm.
Yeah, typically if I've done passive range of motion, it's post-surgically, and so the patient is not able to tolerate this position to begin with. So I just keep them in supine and hold onto their arm and allow gravity to assist us down towards the floor, and I take the measurement that way.
So what she's talking about, that's another good way to do it. And then scoot over towards the very edge. So what you can do is maintain, a pure plane of motion, and you can kind of assess, generally, their ability to perform hyperextension this way. And that brings up one final thought. Just remember that the nomenclature can vary. Okay, so we all call this flexion, and a lot of people call this extension, and then this is hyperextension. Just keep that in mind. For the purposes of testing, we're testing shoulder extension, and we're MMT shoulder extensors, but technically this is a form of hyperextension. Okay, just remember that.
So any extension with a positive number is going to be hyperextension. If it's less than 0, that means the patient cannot get back to 0, cannot get back to that starting position.
So maybe just for the purposes of today, maybe assess the patient in prone through the standardized testing method, and then have them stand up in good posture without compensating, and see if they can go any further. I'm kind of curious to see what you get. So 50 to 60 is normal. Okay.